I just wanted to show one example rather than the statistics about this series. This particular patient was first seen in 1996. Classic symptoms of CFS. Had originally had a diagnosis of Tahoe flu many years before that. Interestingly, developed seizures, which is actually how she came back to my attention. And the serum and spinal fluid were positive for HHV6, again in 2 different laboratories by PCR on multiple occasions. She was identified as having germline integration in 2007 and developed a gamma clonal T-cell rearrangement in April of 2007. This is one of those unique patients that I have about 100 sequential points on over the course of her illness. And because of her significantly deteriorated clinical condition, Vistite therapy was initiated with a marked improvement in her symptoms and a reduced viral load. And this is really kind of impressive because we heard a lot of debate about chromosomal integration and whether you can have active replicating virus or not in the face of chromosomal integration. And I think you'll be convinced that her repeat lumbar puncture viral load is pending at this time. But in the serum, her PCR was positive. She remained positive, as you would expect, because she's chromosomally integrated, but her viral load dropped from 46,000 to 3,000 over the course of therapy. And again, her spinal fluid did convert to 6A negative by PCR, and I'm awaiting that viral load result. So this is pretty impressive. There's another wrinkle to this story. Along the line of her illness, her father, who's 76, was hospitalized with acute encephalitis in Boston, actually, and defied diagnosis there. And finally, her attending infectious disease doctor called me and said, "Do you have any ideas about this? Because I know the daughter's been very sick." And I said, "Check for HHV6. And her father, as well, was extremely positive and was ultimately treated with cidofovir and has had a full recovery, although his recovery was much, much longer. He was much more acute and encephalopathic. So I think there's several interesting points to be gleaned by that particular case. The second case I wanted to talk about, again, to tie together a lot of the things we heard in the first 2 days with treatment, is a very interesting case that Tony will probably remember, who was part of the original epidemic, was quite ill, had seizures, was lost to follow-up, and ultimately came back to the northern Nevada area. And he came back in a very unfortunate condition. He had intractable seizures and mesial temporal sclerosis and was in a nursing home. And the physician who was making rounds in the nursing home said, "You know, he keeps having fevers and his symptoms wax and wane, and it's just not the usual thing that I would expect to find in this kind of patient." So we proposed diagnostic studies. And this relatively young man indeed had positive spinal fluid for 6A. He underwent a 6-month regimen of cidofovir. His spinal fluid converted to 6A negative, as did his serum. And we also have viral loads in this man, and he is not chromosomally integrated. The reward in this case is that he's out of the nursing home and is working part-time as a carpenter. So, perhaps the most provocative portion of this brief talk here is that if you further hypothesize that co-infections with unknown viruses and 6A can trigger persistent CFS and result in a dysregulated immune system, as evidenced by gamma T-cell rearrangement, this may lead to the development of lymphoma. And I want to just briefly go over some statistics and tell you why I'm concerned about this. We've now found 59 patients who have gamma T-cell rearrangements, and don't worry about which ones were positive for 6A and 6B, et cetera, et cetera. That's not the point of this. And amongst that group of patients, 19 of them have developed B-cell lymphomas. And these were all part of the original cohort that had been followed for many, many years. So that's, and without dissecting this and spending a lot of time on it, it appears that some of these patients who have had chronic documented infections for many, many years have developed T-cell abnormalities and subsequent B-cell malignancies. And we're very actively investigating any kind of cause and effect relationship here. And the obvious question one has is, can you impact this process perhaps with antiviral therapy? So this is a picture that I borrowed from Andy Kogelnick, but I was hoping he was here to amplify it because it's from his School of Informatics. But I make a plug for this approach. I think we've really reached a time now where our old model of health, illness, evaluating, testing some more, trying some empiric therapy and seeing what happens, and disease progression and prolongation is probably seen its better years in medicine. And I really think we have the tools now that can help a clinician make a quicker and better decision. And what I mean by that is, in the world of informatics, we can share information on profiles, we can get genetic profiles, we can get expression arrays, we can get viral arrays that make these patients more easily subdivided. We can make a quicker decision, we can decrease their morbidity, and come up with more rational, aggressive, and probably helpful therapy. And I make a plug to everybody here to sort of adapt this mode of thinking with respect to patient care in this group of people. And thanks very much.